Emergency medicine is more than just ordered chaos.
From the resus room to the bedside, we are witness to it all.
And we're here to help you prepare for it.
Bringing you the brightest minds in emergency medicine from around the world for trusted, tried, and true free open access medical education.
I'm Dr. Anton Hellman.
And I'm Dr. Katie Lynn.
Katie, let's welcome the listeners from our amazing EM community to the Emergency Medicine Cases podcast, shall we?
Yeah, or let's simply call it EM Cases.
Okay, EM Cases.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
The 2025 AHA ACLS guidelines, informed by the International Liaison Committee on Resuscitation, ILCOR, reinforce many things we already know, which we covered in episodes 169 and 170 in 2022. But they also expose where the evidence is weak, where practice has drifted, and where nuance matters most for emergency physicians running real resuscitations. I just have to say off the top that while we should know what's in the guidelines, and they're generally pretty good, they're designed for office-based physicians who rarely run codes of arresting patients. And that's not us. The guidelines really are limited. For example, for VFib arrest, after 3 shocks, epi, and amio, the guidelines recommend, well, nothing, because they feel there's not good enough evidence. But we need to know what to do based on the best evidence and expert opinion. We need to go beyond the guidelines and dig into the nuances of care. And we all know that no matter what the evidence, there are so many variables and factors we need to consider in real practice that no study addresses. Today's episode is a practical update on adult cardiac arrest management, with a particular focus on high-quality CPR, defibrillation strategies, refractory VF, POCUS during arrest, and post-ROSC decision-making. And to help us separate signal from noise, I'm joined by 2 world-class experts. Dr. Sheldon Cheskis is an emergency physician, researcher, and internationally recognized authority on defibrillation, CPR quality, and resuscitation science. Welcome back, Dr. Cheskis. It's great to see you, Sheldon.
Thanks. Really excited to be here.
And well known to our emergency medicine cases listeners, the creator of our POCUS Cases video series, Dr. Rob Simard, emergency physician and educator, master clinician, researcher, and expert in the use of POCUS during cardiac arrest. Welcome back to the show, Rob.
Thanks for having me, Anton. I could talk about ACLS all day long, so I'm super pumped about this.
So let's start off with a case. A 54-year-old man collapses suddenly at a soccer game. Bystander CPR is started immediately. EMS arrives, confirms ventricular fibrillation, and begins resuscitation. By the time he reaches the ED, he's had 7 shocks, 3 doses of epinephrine, and he still has ongoing high-quality CPR. So, Rob, before we dig into the nitty-gritty, I think we just need to take sort of a bird's-eye view of what really matters. Could you just remind our listeners what we currently know in 2026 based on the best evidence, what actually makes a significant difference to outcomes like survival to discharge, or even better, survival to discharge neurologically intact? What really makes a difference for outcomes?
Yeah, so great question. We really want to do the things that matter and do them really well and avoid the things that don't matter. So what you want to do is you want someone at the scene recognizing the seriousness of this and immediately activating emergency response. So getting 911 there on the scene where we can have experts who deal with this every day involved in this. Meanwhile, while that's going on, you want bystanders to immediately jump in and start doing high quality CPR on this patient. Now, it's not just good enough to do CPR. You need to do high quality CPR, the right rate, the right depth. You need to be able to do it at the right ratio where ventilations are done appropriately. You need to allow full recoil of the chest. And you need to make sure that you're getting fresh people every 2 minutes to do the best they can to give this 54-year-old the best chance for survival. Someone's getting an AED. They're readily available. You can get apps now that direct you to AEDs and get that patient shocked if they're in a shockable rhythm in a very timely manner. When advanced crews arrive, you want the advanced crews, the experts that do this every day, to be involved, to do the other things in the guidelines, the medications, the use of a defibrillator to shock the patient if they have a shockable rhythm, to recognize what rhythm they're in, and manage the patient in the appropriate algorithm. Assuming you get ROSC, you can then go and get this person in a center that is designed to deal with these complex patients who have had cardiac arrest. Multifactorial things like having an ICU where they deal with cardiac arrest patients, not a satellite ICU that doesn't see these sick patients. Having all the right experts, the cardiology team, the neurology team, the people that deal with people with cardiac arrest that can get you that best prognosis involved in this patient's care. And when this patient survives and has, a good neurological outcome and can go home, that they have the right supports at home and the right supports in the community to essentially help them even months later after their cardiac arrest, deal with all the things that may arise. And what I just went through is something called the chain of survival, the links in the chain that give you the best opportunity to have a good outcome in cardiac arrest.
So just to summarize there, it's really the chain of survival, and it is 6 things. It's emergency activation, high-quality CPR, defibrillation, advanced resuscitation, post-arrest care, and recovery and survivalship, which is further ongoing care long after they've left the hospital. And of course, our job is really important when they come in, and we need to give them high-quality CPR and the defibrillation and the advanced resuscitation, as well as the post-arrest care, getting that started. So we're going to break those down one by one. Let's start with the emergency activation. Now, this isn't happening in the emergency department usually, but Sheldon, can you just give us the latest and greatest on getting those patients started on high-quality CPR and getting them defibrillated in a timely fashion?
Yeah, I think what we've recognized now in resuscitation science is there's no silver bullet. There's not one drug or one strategy that's going to make a difference. And certainly, if you want the biggest bang for the buck, the biggest bang for the buck is the proximal chains of survival, the recognition and early activation of the EMS system. So for me, the first contact with the system is activating 911 and the use of dispatcher-assisted CPR. This has really improved the rates of bystander CPR. Recent article came out of Korea looking at video-assisted CPR. So actually being able to visualize a bystander while they're doing CPR greatly enhances the quality of the bystander CPR. So activating the system is one. How do we get as many bystanders to the scene as possible? Rob did a great job in talking about crowdsourcing, the use of pulse point, first AD, the use of apps in many jurisdictions, particularly in Amsterdam, Sweden, where they have large volumes of public responders who are responding via app to cardiac arrest and actually providing CPR and the first defibrillation long before EMS gets there. And that's critical. If you want to survive cardiac arrest, you need to defibrillate people as early as possible, and these mechanisms are actually doing it the best. Sweden is leading the world with respect to drone delivery of AEDs, using drones to get AEDs to locations in rural and remote communities, but encompassing that with community responder programs where we actually dispatch community responders to the areas of cardiac arrest. This all focuses on trying to deliver the shock as early as possible. So it's not just thinking about police, fire, ambulance, community responders, drone-delivered AEDs, dispatcher-assisted CPR. This will all improve the time to first shock, which is absolutely critical. Certainly, once my EMS crew's there, the focus on stay and play versus load and go has really been demonstrated to improve outcomes from cardiac arrest. And I think Rob probably sees it in the emerge yourself, Anton. If we don't get Ross by the time the patient comes to your emerge, the likelihood of survival is incredibly low. And the number of interventions that paramedics can do on the scene, for the most part, is exactly the same as what we can do in the ED. So this actually gives them the best chance for survival. So this idea then of where we're going to take the patient to, the idea of sending patients to organized community centers of excellence makes a lot of sense. Taking a patient to a place where they see cardiac arrest, they do PCI, they do targeted temper management as part of a regular treatment of patients. That's where the focus is. So really, if we can make a big difference in those proximal chains, those systems have historically shown great survival rates. And again, look at places like Amsterdam, where they've really improved these findings. The Netherlands, just incredible survival rates. That's where you get the biggest bang for the buck.
Interesting. So just getting the AED there faster is going to really make a big difference. And I just think it's so super cool that they have drone delivered AEDs.
Mm-hmm.
Have you guys actually seen that happen and work?
Yeah, so that's where really one of my research focuses. We're just right now doing a heart and stroke grant to look at drone delivery of AEDs. We did a lot of the original feasibility work in the region of Peel and Caledon. We found that there's no question the feasibility of drones is very, very possible. So we've done all the work there. The key issue and the reason we've taken so long is getting the regulator on board. So the regulator, Transport Canada, NAV Canada, now we have our approvals. We're the first in Canada to have an approval to fly a drone for acute medical emergencies. So we're not just doing cardiac arrest. We're using in a drone epinephrine for anaphylaxis, Narcan for opioid overdoses, a stop the bleed kit. Because to me, what you want to actually address in these communities is time-sensitive medical emergencies, not just cardiac arrest. There are multiple interventions that we can make a difference for. In the future, I guarantee you, you'll see blood being taken by drone to the scene of trauma. So this is all possible. Hopefully we'll see some of this happen in Canada as well.
I want to move on to CPR quality. We know that CPR quality is one of the only interventions clearly linked to meaningful survival, yet performance varies widely. Rob, what are the most common CPR quality failures you see in real resuscitations, and how do they actually affect the physiology in cardiac arrest?
Well, first off, Anton, I must say doctors are some of the worst at performing CPR. They haven't taken a basic life support course since medical school. Doing high quality CPR is hard. When I'm teaching my BLS and ACLS courses, I tell the participants that, you don't have to go to the gym after taking a CPR class. Like, it's a workout to do proper CPR. Now, in the resuscitation room, when I'm leading a code and I'm checking out the quality of the CPR, some common failures that I see are the speed of the CPR. Like, you got to hit your targets. You got to hit the targets. 100 to 120 compressions per minute is the target for CPR. Going too slow or going too fast is detrimental in providing the blood flow that's needed to the heart, to the brain. You need to be able to do it such that you're compressing deep enough, 5 to 6 centimeters of the chest, to ensure that you are pumping the blood to the places that matter. Now, another thing that I commonly see is that as people get tired, they start leaning more on the chest. They don't allow that full recoil of the chest. You need to do those 3 things very well. You need to go at the right speed, you need to be deep enough, and you need to allow full recoil so that heart can fill during the full recoil and that you can empty that heart to get the blood to where it needs to go at the correct speed. Now, there are some people that try to be a hero in cardiac arrest, and they're like, well, I'm fit. I'm going to do my 2 minutes of CPR, and I'm going to do another 2 rounds of CPR, and that is not good. What you need to do is you need to change compressors every 2 minutes. We know that even after 45 seconds of high quality CPR, that the CPR quality and the metrics get poorer. So every 2 minutes, you're switching to a fresh compressor who can go ahead and hit those metrics. One of the other things that I see is that we ventilate far too fast in cardiac arrest, that we're ventilating way faster than the recommended amount. If you're at the head of the bed and you have the hand on the bag and that patient is intubated, you're only giving one breath every 6 seconds. Count to 6, give a breath. Count to 6 again, give a breath. Hyperventilation is detrimental in cardiac arrest. And then finally, feedback devices, or if you don't have feedback devices, a CPR coach can be helpful in the room where a dedicated person is watching the CPR quality to make sure it's high quality CPR at all times. Or you have a machine that's detecting your rate, detecting your depth, detecting your full recoil, and telling you to push harder, push faster, or it'll tell you good CPR. And that's kind of what you want to have to make sure that you're giving that feedback, that you're doing things appropriately to give that 54-year-old the best chance of survival.
They seem like such basic things that are so super important. As I was listening to you, Rob, I'm thinking, well, this is stuff that anyone who's taken an ACLS course would know. But it's precisely these things that I think as a physician in the emergency department, we don't pay that much attention to. And it's just so important to make sure that our training, especially, and then if it's not being done right in the emergency department, we've got to correct it immediately. And so we need to get into all the nuances of how to get all those basic things right. Sheldon, any comments about CPR quality?
Yeah. So the biggest issue in CPR quality is you don't measure. So while Rob did a great job in reviewing the targets, if you don't actually measure it and provide feedback to your providers as to how they're doing, you never know how people are doing. I can tell you when we first started doing CPR quality studies in the Resuscitation Outcomes Consortium 20 years ago, there was not one place on earth who was doing high quality CPR when we actually measured it. When you measure it, that makes a huge difference because then you can feed back to your crews and say, hey, listen, your depth, some of these parameters need to be improved. And that actually developed a Hawthorne effect where people actually started really focusing on their data, measuring their data and improving that quality, which directly related to improve outcomes. So I think knowing the targets is one thing, measuring them and feeding back to the providers, that's much more powerful in terms of improving outcomes.
Absolutely. So measuring CPR quality is key, and we're going to get deep into exactly how to measure CPR quality, what really matters, what the evidence is, and how at the bedside we can actually make sure that we're doing good quality CPR. We'll talk about that a little bit later, but I want to talk now about pulse checks and CPR. So we know that long pulse checks destroy high-quality CPR and rapidly decreases cardiac and cerebral perfusion pressure. So Rob, I know this is a topic that's dear to your heart. How do you suggest we minimize interruptions in CPR in terms of pulse checks?
Excellent question. And it's all in the preparation of thinking steps ahead in cardiac arrest. So when you're that code team leader, you're not just in the moment of what's going on right now, you're thinking that one step ahead. You're thinking what is going to be coming up. So if that pulse check is coming up, you already have an idea of what you're doing at that pulse check. You have your fingers ready on the pulse when the last few compressions of CPR are happening. You have your monitor visible to you so that you can do your rhythm check simultaneously with your pulse check. And, if there's someone at the head of the bed and you're at the foot of the bed and you're on the femoral pulse, you have somebody on the carotid pulse as well and you're ready to go. And that when you're doing your pulse check, you are minimizing the amount of time it's taken to do the following. Analyze that rhythm, feel that pulse. If it's shockable, get your machine charged during the last few compressions of CPR, ready to go so that it's already charged. And if you see that VFib or pulses VTAC rhythm, that you're clearing and shocking and getting that done within the 10 seconds, and then getting right back on the chest to resume CPR to minimize interruptions. Now, if you're like me and you like to use other things that can help you, like an ultrasound machine to do a pulse check to, really target where that pulse is, once again, you have that machine on, plugged in, positioned where you want it in the room, and you have that probe in your hand during the last few cycles of CPR so that you're ready to go. And then when you see that pulse on the screen, you are centering it and you are putting your fingers right below that pulse so that you have your fingers right in the heart of that carotid artery or right in the heart of that femoral artery so that you know you're in the optimal geographical space for you to have that pulse visible. Just like intubation as well, you want to have your most experienced people doing these things. You don't want to have your first year medical student who wants to help out do these things. You want people who are experiencing cardiac arrest being involved in these critical things such as, does this person have a pulse or not?
I just want to talk a little bit more about POCUS pulse checks. We've talked about this before on EM cases, but I think that there's the POCUS converts out there, and then there's the POCUS naysayers.
I call them POCUS haters.
POCUS haters. Could you just give us a little summary of the evidence for POCUS pulse checks versus manual pulse checks?
Yeah, so POCUS pulse check, it's a relatively new thing in the cardiac arrest world. The guidelines make absolutely no mention of a POCUS pulse check. It's a tool that sees inside the body. So being able to see exactly where the carotid pulse is and being able to put your fingers right in the heart of the carotid artery, how could you not agree that that would be a more optimal way than to blindly feel somewhere in the patient's neck or somewhere in the patient's groin for a pulse? The other thing too is that, it's one of these things where we can look at pulsations of the artery to give you an idea if there's any output or flow through the artery. It's very clear when someone has no output through an artery on the POCUS pulse check versus someone who has output of flow. And it's really kind of like a poor man's art line in terms of you don't have to spend the time it takes to put an art line in to be able to give yourself some information. Although I consider an art line a gold standard in cardiac arrest, POCUS, I feel, is one of those things that is readily available in every emergency department now and is something that is readily available to help you, finesse that resuscitation a little bit more and know another data point that, when done properly, doesn't affect your time off CPR and can really be done during that ACLS minimized standard of 10 seconds of pulse check.
Absolutely. Sheldon, any comments?
I totally agree with Rob, and that's why certainly at AHA this year and some of the work we're doing, we're looking at the flow patch device, a device that sits on the carotid artery. It's non-invasive and gives one a sense of flow through the carotid artery. And assuming that we have flow, then you have flow to the brain, which is what is critical to neurointact survival. So I think what you're going to see in resuscitation is more focus on non-invasive measures to assess flow. One of the issues with some of these devices is they actually assess velocity, and velocity is not the same as flow. And I think that's a critical piece that we need to sort of get our head around. But I think, again, these non-invasive flow patch devices are really going to show some promise in our ability to assess resuscitation quality.
All right, this actually might be a good time to talk about conflict of interest. You had mentioned a product. It's a patch that you put on the carotid. That sounds very cool. Sheldon, if you could just give us any financial conflicts of interest.
I have no conflicts of interest whatsoever with this product. We are using it in a study, but I have no conflicts of interest. And I have received funding from Zoll Medical for instructional resuscitation talks, but otherwise have no conflicts of interest in resuscitation science.
All right. And Rob, do you have any conflicts of interest when it comes to resuscitation and cardiac arrest?
I have no conflicts of interest. I do teach numerous BLS, ACLS, and PALS courses throughout the year, and I also do teach POCUS courses throughout the year, which I am paid an instructor fee to pay those fees. I'm an instructor with the Heart and Stroke Foundation, and I teach to the guidelines when I'm teaching.
We talked about some of the CPR targets like depth and recoil and all of that, but there's also some other CPR targets like end tidal CO2, diastolic blood pressure, and compression fraction. Sheldon, of these physiologic CPR targets, again, end tidal CO2, diastolic blood pressure, and compression fraction, which one or ones have the strongest causal plausibility? What do you suggest that we actually try and measure at the bedside, and why?
It's a bit nuanced because it depends where the resuscitation is taking place, right? So, if it's an out-of-hospital resuscitation, compression fraction is a post hoc variable, so we don't see that. But what we do see is end-tidal CO2. So, a sudden rise that's sustained in end-tidal CO2 is generally a very, very strong marker for ROSC. So I think that would probably be the number one in terms of a target for successful resuscitation. In Europe, in the in-hospital care, no question, we see much greater use of ART lines during resuscitation, both pre-hospitally and in-hospital. And no question, mean arterial pressure would be the target I would be looking at. So I agree with Rob's previous comment that I think the ART line is the gold standard for resuscitation. We just don't do it in pre-hospital care in Canada, but in Europe it's done. And obviously in the emerge departments, I think it's done as well. So that would be my goal, the mean arterial pressure.
All right, we'll talk a little bit more about putting in an A line or an ART line or an arterial line, whatever you want to call it, in the emergency department and some of the logistics around that. But I want to talk about another way of measuring quality CPR, and that is transesophageal echo, which we did cover on a recent Quick Hits episode with Ross Prager. Rob, as a POCUS guru, what's your take on transesophageal echo? Just really, in this discussion, we'll talk about TEE a little bit later in more detail, but in terms of the optimal hand position for CPR, I understand that some people say is a game changer in terms of quality of CPR. What's your take on TEE?
It's still, I think, more in its infancy in terms of where it's being used, the number of people who are trained to use it, especially in the resuscitation world in the emergency department. And also its availability limits some of the factors, but in some places where it is used, it can be definitely helpful in cardiac arrest. With your specific question about hand position, it can give you a good idea of compression quality. And you can get compressors, in fact, to change their hand position during CPR to ensure that you have improved output, essentially with like your left ventricular outflow tract. Like if you're compressing over top of the outflow tract, you're kind of backflowing blood back into the heart. What you want to be doing is you want to be having good hand position, that you're compressing the ventricles such that it's not being impeded and blood flows leaving your outflow tract through that aortic valve. And by having a transesophageal echo in there real time, you can adjust the hand position such that you're improving the cardiac output during CPR. And that's one of the main advantages of having a transesophageal echo during these resuscitations.
All right, great. We'll talk about all the potential uses of transesophageal echo a little bit later, and then again, some of the logistics. But I want to talk more about some of these other quality CPR tools. Sheldon, you had mentioned end-tidal CO2, and I want to dig into that further. End-tidal CO2 has evolved from just a confirmation tool in CPR as also a quality monitor. And while end-tidal CO2 is associated with ROSC, it's not proven as an interventional target. So Sheldon, how should clinicians interpret low end-tidal CO2 values during CPR, and when should they trigger action? Like, should we be titrating CPR to end-tidal CO2 values? Many teams end up sort of chasing end-tidal CO2 numbers without really understanding all the confounders. And can you give us kind of some numbers?
Sure. So to me, I think end-tidal CO2 has to be taken in the context of the patient and the length of the resuscitation. So I would never chase an end-tidal CO2 value. What I would try to do is if I got an end-tidal CO2 that's consistently elevated, I keep going. That suggests I'm doing good quality CPR. If I have an end-tidal CO2 less than 10 for a prolonged period of time, those patients are likely dead. If I see a sudden elevation in end-tidal CO2 that's sustained, that trend suggests to me that the patient has retained ROSC. I think where end-tidal CO2 comes into real issue, as patch physicians, and Rob will know this as well, is when we get a call from the paramedics that they have a narrow complex PEA rhythm and they have an elevated end-tidal CO2, and they're calling for a termination or resuscitation. So those always get me nervous because I think that's a very classic situation for pseudo PEA. And I think that's where Rob's use of POCUS can be very, very effective. So I never like to look at end-tidal CO2 as a single value. I like to look at it in the state of what the patient is presenting at. So it's a little bit more complex to me than a single number, but those I think are really good examples of how to use end-tidal CO2. Intubation, again, end-tidal CO2, seeing a capnographic waveform, that in our system is a must. We do not ever confirm a tube is in place without a capnographic waveform for end-tidal CO2. So lots of uses for it, some good concepts to think about. But again, I try to stay away from a single number. I think that's where you can get burned, to be honest with you.
Rob, your take on the use of end-tidal CO2, and in particular, if you could maybe touch on what might falsely lower or raise the end-tidal CO2 during cardiac arrest, which can explain why we shouldn't be depending on it so much.
Yeah, so I totally agree with what Sheldon had said. I use it very similar, especially that nervousness you feel when they tell you, hey, I got a PEA that's going 90 beats per minute and it's narrow and the end title's 40. Like I sit there and say, yeah, this person has a pulse. You're just not feeling this pulse. And I want to transfer this person in to get a better sense of what's going on in this case. There are some scenarios where I'll take a patch phone call from the paramedics and they'll tell me the end tidal CO2 is 60 and it's been 60 the entire time. And I wonder if that person's just a CO2 retainer and their CO2 is always super high. And then it's like, oh man, what am I going to do with this value? I don't know how to interpret it in this context. So I totally agree with that single digit value. And then also to get like really accurate end tidal CO2s, like you need a good closed system. So if there's, you're bag valve masking the patient and there's a leak in the system, you're not going to get necessarily a accurate end tidal CO2, and you might get a lower number than is what is true with the patient. When they're intubated and you've got it in the right place and you're not right main stemmed or you're not esophageal and you're getting a number, you should get a more accurate end tidal CO2. And then that quality of CPR. And the other thing I find is like if the downtime, if we're not sure about it, this patient's been found and they've actually been down for far longer than we think, their end titles should be lower than the person who arrests right in front of you. So there are some times where you're going to have lower numbers in the context of cardiac arrest or potentially really high numbers in the context of cardiac arrest. But for that, normal physiologic, that case you gave us with this 54-year-old, that presumably normal physiologic person playing soccer, collapsing, et cetera, you're hoping that if you're getting accurate numbers of end tidal CO2 and that you can use those to your advantage as a non-invasive way of having an extra data point to find out if you got that early ROSC, to find out about prognosis, to find out about your CPR quality. I always like when I'm hearing like we're at the scene and we're getting end titles of 25 with CPR. I'm knowing my paramedics are doing good quality CPR when I'm seeing those numbers. And also when they're telling me, hey, we've been at the scene for 15 minutes. Our end title has dropped now. We're at an end title of 8. We're at 22 and now we're at 8. It's an easier job for me as the patch phone physician to say, this is a poor prognosis. I'm getting a number less than 10. This is a non-shockable rhythm. This is moving towards a termination of resuscitation in the field with these data points.
That clears up so many things about end tidal CO2 for me. I hope for the listeners too. Now we really know how to use end tidal CO2 properly in the cardiac arrest situation. We had mentioned arterial lines, and Sheldon, you had mentioned following the map. There's also talk about following the diastolic blood pressure. My understanding is that the use of arterial lines during cardiac arrests are quite weakly supported by the evidence out there, but there's many resuscitationists, and it sounds like the two of you, who swear by using art lines in cardiac arrest. There are, of course, practical considerations if you're running the arrest with just one doc and one nurse, but assuming that you have the person power, Rob, we already talked a bit about how you're convinced that an arterial line is kind of the way to go. Could you just review for us there, again, what are you trying to target? Are you trying to target diastolic blood pressure? Are you trying to target MAP? And if you are, what are your targets? And then maybe some of the logistical aspects of getting an art line in there as early as possible in your cardiac arrest patient.
So having an art line in a cardiac arrest in the emergency department is some kind of luxury. It's not something that frequently happens. For me, at my site, the reality is that it's extra person power to get these in. As you mentioned, we might not have all the resources on a night shift. I might be the only person in the room that has the capability of putting in an art line. And I also have a whole bunch of other things that I'm trying to prioritize in a cardiac arrest. So sometimes they're just not feasible. This isn't like running an arrest in the ICU where it seems like everyone's got lines everywhere and you have an art line in the ICU and this patient's been there for some time and the team's been monitoring them and they go into cardiac arrest. I think that there's value in using that art line when they have it. If you have one, use it. The way that I use it, if I'm the cardiac arrest team leader and my patient has an art line, there's a few things that I do. So number one, I can monitor CPR quality by looking at what the numbers that I get on the art line, what the waveform looks like. If I'm getting diastolic blood pressures that are, greater than 30, I'm thinking that we're doing pretty good quality CPR. If that number skyrockets and all of a sudden during the round of CPR, it went from 30 to say 60, I start thinking I might have ROSC here. And if it's time to give epi, I might say, let's hold off on the epi just until this next pulse check because we've had a big jump in the art line blood pressure reading. The number's gone up quite a bit. And the opposite is true. When you see low numbers, those are poor prognosis. If we're doing CPR and we're getting numbers that are less than 20, or it drops, it was 35 and now it's gone down to 20, I start thinking this diastolic blood pressure is a poor prognostic number. And even with what appears to be high quality CPR, we're not exactly getting metrics that meet something that's going to lead to like a neurological survival intact dispo. This looks more like a poor prognosis. So those are kind of the ways that I use it. And then the other benefit of having an art line during that pulse check, when no one's doing CPR, if I'm getting a waveform on my art line, it's basically telling me that this patient has output and that this patient probably has a pulse, even if I don't feel it, because I'm getting a waveform that shows that there's flow through that art line.
I'm just trying to imagine where I work, if a patient comes in intubated already by EMS and we've already called down our respiratory therapist, they can put in a peripheral art line pretty quickly. And I have to admit, I haven't been doing this in the patients who arrive in cardiac arrest where I work. But if the patient's intubated already, why not just ask the RT to throw in an art line rather than them just standing around?
Yeah, I totally agree. Rob was fantastic. He described the physiology perfectly around diastolic pressure. Certainly the Europeans use MAP. This is a big thing in Europe, pre-hospital care, where you have physicians on the trunks. So they definitely, in their HEMS team, they all use art lines. I just came back from a conference in Switzerland, and everyone uses art lines. So it shows you the difference in practice depending on where you're at. But if you can do it, to me, that's the gold standard. Forget all this end-tidal CO2 stuff. Unless you got an art line in place, perfusion now, right? So the gold standard is being shown for you right in front of a screen. So to me, I think it's fantastic. I don't care if there's a randomized trial that shows it. I don't need a randomized trial. I need physiology. And this is correct physiology. So I'm a big supporter of art lines if it can be done.
I just want to circle back to compression fraction and recoil that Rob had mentioned near the top. We obsess over the compression rate and the depth, but recoil and interruptions may matter just as much. Rob, how do you ensure full recoil during chaotic arrest at the bedside?
Yeah, so it's interesting because during a cardiac arrest, if we're doing multiple cycles, we're going to have multiple people doing CPR. And it's not like these are robots that are doing these, although we do have the Lucas device, speaking of robots, that can do this. But really, everyone has their different unique style. It's trying to hit the right metrics. So I'm a big fan of having either my eyes on the CPR compressor during the arrest, or I'm dedicating a coach to ensure that we have high quality CPR. So a coach is someone whose job is to just provide feedback to that person during CPR, or a machine is telling them this by some sort of feedback device, whether it's the machine saying like good CPR, meaning that they are doing the recoil, the depth, and the rate. You will get those three metrics on a standard feedback device. Also, like the eye test, like if someone's getting tired and they're starting to lean more forward and putting more pressure on the chest, I know they're not allowing full recoil. So I'm constantly saying like, good CPR if I see it. Give them that feedback that that's good quality CPR. That's what we want to see. Or you got to allow full recoil. I'm not such a big fan, although I know some people are, of actually lifting your hands off the chest and then putting them back down on the chest to do the next compression. But near close to that, where you're almost allowing your hands to almost fully come off.
All right. I mean, that flows nicely into a discussion about feedback devices. I want to talk more about those. There's metronomes, there's analog tactile clicker devices that produce a clicking noise and sensation when sufficient pressure is applied with the chest compressions. There's digital audio visual feedback devices. Sheldon, what's the evidence behind feedback devices? Which ones are the best in your opinion, and how should we utilize them during the arrest, if at all?
Yeah, no, I'm a big feedback device fan. Again, no randomized trials showing feedback devices are associated with improved survival, but plenty of observational evidence that shows that CPR quality improves with the use of feedback devices. That there's zero question about that. So I think they're fantastic in training. And our paramedics, certainly we've been using feedback devices for 20 years. So we use a Zoll X Advanced device. You see the actual compression rate, depth, and velocity on the actual screen, so you can actually see how you're doing in real time. Feedback devices are going to be effective. They have to be activated in time. We now have actually ventilation feedback devices that give feedback on ventilatory rate and tidal volume. And I think that's going to be the great frontier. I think we've convinced ourselves that feedback devices work well. To me, the best ones are the ones that actually are incorporated into the defibrillator itself. So you're seeing everything on the screen. You see the rate, you see the rhythm, you see rate, depth, ventilation, as I mentioned now. Those are the best because they're the easiest to use. I find that standalone devices that have to be somehow manipulated to provide device, I find those the worst, to be honest with you. I think they're not incorporated into the defibrillator. I'm not a big fan. So I like a device that actually has it in the device itself. Again, the key to CPR quality and feedback is to measure and provide feedback. So real time is great. After either resuscitation, getting back to the paramedics on how they've done in these particular cases makes a huge difference. So I think Rob's comment on the debrief is really key because that's when you find out what you did well, what you didn't do as well. So again, big fan, no randomized trial evidence to improve survival, lots of observational evidence that improves CPR quality, which we do know is related to survival.
I suppose that even if there's no good RCT evidence that CPR feedback devices do save lives, and you might not be fully convinced that they're great, one of the potential uses of CPR feedback devices, I think, is for quality improvement. Imagine that if the data were collected from CPR devices for all the cardiac arrests in your hospital, you might even be able to identify those who need more training in CPR. You might be able to identify those who are great at CPR to teach the people who aren't great at CPR. Just some food for thought there. I think for quality improvement, they've got to be valuable. I mean, we're going real deep on CPR here, but we still haven't even touched on head-up CPR and mechanical CPR. So we gotta hit that. We've talked about pulse checks, we've talked about CPR physiologic targets, we've talked about end-tidal CO2, we've talked about blood pressure monitoring and heart lines, compression fraction and recoil, and feedback devices, but we're not done yet. I want to talk about positioning for CPR and head-up CPR. Rob, what about head-up CPR? Like, we know for airway management that there are distinct advantages to keeping the head up. We know for raised ICP that it's a good thing. We know for severe asthma, for a whole long list of conditions, getting the patients to sit up or having their head up as much as possible is a good thing. It's good for their brains, it's good for their lungs, it's good for their breathing. So it kind of makes sense that it would be good for the cardiac arrest patient. I understand that there's 3 small studies that suggest improved outcomes with head-up CPR. What you're doing is you're tilting the patient into reverse Trendelenburg, and you're starting chest compressions that way. Could you just tell us a little bit about the rationale, what the evidence is for heads-up CPR, and what your kind of bottom line take-home is for it?
So I think the answer for today is that there's no great proof that we should alter our patient position for CPR. And maybe the answer is going to be maybe never we should do this, but more research is going to be needed to show if this is going to be effective and show improvement. Like, I get the rationale. The elevated position reduces venous pressure in the brain, while improving blood flow to the heart and brain. So, we like that. We want to improve blood flow to the heart and brain. So, in theory, there may be some good to this, but here's the big problem, Anton. If you put somebody into reverse Trendelenburg, you've made CPR incredibly hard to do effectively. You're now doing CPR at a sloped angle, and that's not going to be as effective as doing CPR on someone who's lying horizontally. So you're going to need to use devices now. You're going to need to use a mechanical CPR device. And then you're going to need to use an impedance threshold device as well to ensure that you're having some good quality CPR and to be able to provide the patient with the outcomes that I'm sure we want to see, which is improved brain and heart function post-ROSC. So the studies are small, and in fact, they're conflicting. Some studies show that there may be an improvement in ROSC and survival. Some studies show no significant difference. So I think we're going to need more time to get some really good studies in this to find out if this is something that we should move to or not, and that we change the way we do CPR in the future, or if what we're currently doing with the horizontal patient, doing CPR at the horizontal level instead of some inverse Trendelenburg angle, is the way to go.
It sounds like maybe if you combine head-up CPR, mechanical CPR, and an impedance device, that might be like the golden answer to amazing CPR and quality. And the whole conversation we've had up until now is kind of moot if we can get that set up. Is that a ridiculous notion, Sheldon? What do you think?
Heads-up CPR is three things. It's elevation, use of an ITD, and you have to have a mechanical device. Can't be done without a mechanical device. So whenever you have three variables, the question is which of those variables is making a difference? Is it the ITD? Well, in randomized trials, look at the ITD alone, it didn't make a difference. It does make a difference, I think, if you get it on early enough. When you see it done in the pig lab in Minnesota, no question, ICP drops. The trouble is replicating animal studies in real life is a real challenge. So in Minnesota, they've had great success with heads-up CPR. I think they get the ITD on early. No other place really has been able to replicate those studies. The other issue with heads-up CPR is when you talk to the medics, there's no question the lucus migrates. You have the mucus on a 45-degree angle, it migrates. So eventually, we talked about outflow tract, it actually moves away from where you're actually supposed to actually compress the chest. So it's feasibly very, very challenging to do all these things at one time. So I think I've given a lecture on heads up. I think it's a cult. I think there's a cult following for heads up CPR. But until such time as it's proven, and again, in a randomized trial, I'm not buying yet. And there's plenty of people outside of me who probably give you the same feedback.
All right. I'm just dreaming here, but I'm still thinking, heads up CPR with a mechanical device and an impedance device and maybe transesophageal echo as well to prevent migration. You send that to a cardiac arrest center, and that's going to give you your best outcomes. That's just, I guess, in the ideal world, but I guess we have to go back to reality. For most of our listeners, that's not going to happen. Although, there is an argument to be made that mechanical CPR does have a role, definitely in prolonged extrication time in the field. And then those patients that come in severely hypothermic, where they're not dead until they're warm and dead, definitely a role for mechanical CPR there. Agree?
Yeah. So again, I think people have completely misinterpreted the mechanical CPR recommendation in the current guidelines. So basically it says that mechanical CPR should not be done routinely. And I believe that to be true. I think if you can produce high quality manual CPR, then there's no need for mechanical CPR. We've done plenty of studies in our area that showed even in transport, our quality CPR remained high because we had relatively short transport times. Where you really want mechanical CPR, and it says this actually in the guidelines. So you have long transport times. You have rural areas with single responders. Mechanical CPR makes all the sense in the world. If you're doing a transport forth from the field to the EPCR lab, you have to have mechanical CPR. So there are circumstances where mechanical CPR makes a lot of sense. But for routine use, I would agree with the guidelines. I don't support their benefit in routine use. And there's no evidence that's ever been shown in a randomized trial that shows superiority to manual CPR. So that's my take on mechanical CPR.
I also feel from a mechanical CPR perspective that there's a bit of a learning curve when using it in terms of getting it on in a timely manner to really minimize that interruption in CPR. So academically, I may use it in a case where we'll say, I'm still going to run the arrest a little bit longer, but I think this is trending more towards termination. And there's some people in the room who haven't had a chance to use the mechanical CPR device that may need this one day on those indications that you mentioned where there is potentially evidence for it, where we get it put on, we debrief afterwards to find out how we can best troubleshoot this the next time so it goes on smoother, faster to help out. So there's an academic use for it, given that we're kind of in the infancy for mechanical CPR. I feel like in the next decade, the mechanical CPR is going to become better, hopefully put on faster, and the migration issue will become less of an issue, et cetera.
Yeah, plenty of the early research studies on mechanical CPR were all negative. And they were all negative because the delays in CPR were so long. But now you put mechanical CPR, it's got to be on within 10 seconds. To do it within 10 seconds, you have to practice. So I think there's a huge learning curve. And I like how Rob is using that, because when there's a case where it will be a benefit, if you've trained to put it on quickly, you could potentially make a difference. So I think that's a fantastic comment Rob made there.
That brings up the point that we really should be training like, NASCAR pit stop, for the Indy 500. The way those teams can change a tire within 10 seconds is unbelievable. Whereas I think it's even less than that. Anyhow.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
Let's move on now to talk about breathing. All right. A little background first. We know the 30-2 ratio in basic life support, BLS, 30 compressions, stop compressions, 2 breaths, repeat for 5 cycles. That's the way to go for basic life support. But that's without an advanced airway, of course. So once we've secured an advanced airway, then it's continuous CPR and breaths every 6 seconds. Now, we all know, just like CPR going too fast or too slow, that hyperventilation and hypoventilation lead to bad outcomes. And really, it's the hyperventilation that happens all too often when we're all revved up in the heat of a cardiac arrest. We know that ventilation mismanagement done wrong can be one of the biggest iatrogenic harms during a cardiac arrest. So, Rob, how does hyperventilation lead to badness during CPR? And how do you suggest we ensure that slow, one breath every 6 seconds? Is it good enough to say the word Mississippi between each breath, or can we do better than that? What do you think?
Yeah, like hyperventilation is bad and it is incredibly easy to do. If I'm running like sim sessions with my residents and, if it's being recorded, I'll ask the person at the head of the bed who's taking care of the airway, how did that go? And they go, oh, yeah, it was all right. Like I got the tube in, everything was good. And I'm like, how fast were you bagging that patient? When they're watching the video, they're mortified to see that they're bagging the patient like 1 breath every second. And they're giving like a 60-second bag valve rate on this patient. And I always joke with them that person at the head of the bed usually bags the patient as fast as their heart rate's going. But at the end of the day, we have to do a really good job at ensuring that we are ventilating at the right speed. And that speed is 1 breath every 6 seconds. There's a couple ways to do it. Like you mentioned, the Mississippi, that'll work. 1 breath every 6 seconds is an appropriate way of doing it. So if you're going to count to 6 and then give a breath and then count to 6 again and give a breath, that's adequate as long as you're keeping on that 1 breath every 6 seconds. There's a couple of other ways. One way that could work is if you're watching the person doing chest compressions, when they get to about 10 to 12 chest compressions, You can count them out and you'd be like, okay, that's 12 compressions, give a breath. Okay, that's another 12 compressions, give one breath. And if you do that, then you're really working those ratios of giving one breath every second. So using the compression of breath ratio of 12-1 or 10-1 or whatever number you're going to use to get the one breath every 6 seconds, that can also be very helpful.
That's a great pro. Love that.
Now, there's a lot of concern with hyperventilation. Like, let's take a look at what it does. So, I mean, you're decreasing venous return to the heart. That's essentially what you're doing. You're increasing the intrathoracic pressure. You're getting less flow to the brain, less flow to the heart. You're basically, causing coronary and cerebral ischemia, which is ultimately going to lead to poor outcomes and less survival. So it is detrimental to the patient if you're hyperventilating them. Really focus on that one breath every 6 seconds.
Fantastic. Sheldon, I understand you have a keen interest in this area of ventilating at the right rate. How do we do it at the bedside?
Yeah. So again, for us, I think ventilation now is going to be huge. We spent so much time on the C of CPR. We haven't spent enough time on the P, the pulmonary piece. And I think we know very little about the ventilation other than we haven't studied it very well. And most of the guidelines are really based on very, very poor science. So the 500 to 600 ml tidal volume is very, very poor science. So I think what you're seeing now, certainly in pre-hospital care, is the advent of ventilation feedback devices similar to what we see with CPR quality. So you'll see on the screen of your defibrillator the ventilatory rate, the tidal volume, and that's been shown not only in simulation studies, but in our own work. We've definitely been able to show an improvement in ventilation quality when you use a ventilation feedback device. So I think this is going to be the future. We're just doing a randomized trial to see whether a tidal volume of 500 to 600 is superior to a tidal volume of 300 to 400 for cardiac arrest resuscitation and outcome. So I think there's a lot in the ventilation side. We focused as well on the use of BVM, supraglottic airways, and endotracheal tubes. Now we're starting to see, particular again in Europe, the use of ventilators to control ventilation. So as opposed to a manual person doing it, they sent it to a CPR mode, and that CPR mode provides the ventilation. So think about cardiac arrest. You can have mechanical CPR. You can have a manual ventilator. You don't have to do anything. You just sit back and watch to see if something happens with our various parameters. But I think the concept of asynchronous ventilation, the use of ventilators for cardiac resuscitation, you're going to see that more and more now as we realize that ventilation is a big problem. Again, remember, we have no data. No one was measuring this, right? Now that we have parameters, we're able to measure it, we see we have a problem. So I think this is going to be an area of real research moving forward.
All right. So to our future, we can add to heads-up CPR, mechanical CPR impedance devices, and TEE. We can add putting them on a ventilator early.
Yeah.
So it's all going to be machines. I love that, Rob. You had mentioned the 12-1 ratio of the compression rate, the chest compression rate to one ventilation. That's called the compression adjusted ventilation, or CAV, right?
That's right. Yes.
Excellent. Hopefully we'll see some more research about that. And it's surprising that there's so much evidence around good quality CPR and defibrillation, but we know so little about ventilations. It's now time to move on to defibrillation and refractory VF. So defibrillation is deceptively simple. You push a button and shock, but we know that technique matters. Sheldon, what are the most common defibrillation mistakes that reduce success despite doing everything in the book?
The number one and probably only mistake is you put the pads in the wrong position. I think for a long period of time, we've been placing particularly the lateral pad and the AL pad position far too anterior, far too inferior. So if you actually look at some of the pictures of where pads go that are put out by the defibrillator manufacturers, most of them are defibrillating the spleen. Very few are defibrillating the heart. So I think if you look at the current recommendations, both by ILCOR, ERC, and AHA, getting that lateral pad into the mid-axillary line, getting it high, that's actually where the pad should go. And very few times does a pad actually go there. I think we've, for a long period of time, feel that AL defibrillation is the way we start. So everyone starts in AL. So people say, like, why do we start in AL? We start in AL generally because it's quickest and easiest, right? So the quickest decreased time to defibrillation. But certainly we've done a fair bit of research now on current delivery during defibrillation. And there's very little question in our research that the AP plane is where you get more current through the ventricle, and current is what matters. Everyone thinks it's energy, give them more juice. It's actually current that makes a difference. More current goes through the pads and the AP position. So I would argue that for years we've been doing AL first. To me, AP first is actually physiologically more likely to be successful. So even if you take a couple more seconds to go in the AP plane, your defibrillation is more likely to be successful. And this is research we're hopefully going to publish very shortly that will show this. So to me, if you really want to make a difference in AL defibrillation, make sure you got the lateral pad in the right place.
It sounds to me like part of the reason why the number one mistake is pad placement is because we're just using AL in the first place. Maybe we should just be using AP only. I guess there's logistics of flipping the patient over.
Yeah.
Let's get more into pad placement here. That's my first question is, do you recommend AP at the onset? And if you do, how do you logistically do it? And then the second thing is that just confuses me a little bit is that I've read the AFib studies, which show that AL is better than AP. So then how could it be that for AFib, AL is better than AP, whereas for cardiac arrest, AP is better than AL? So let's tackle those two questions separately.
Yeah, no, for sure. Our resuscitations all begin in AP now. Again, many European sites, many sites in North America start AP first. When we were doing dose VF after 3 AL shocks, it was very simple. 30 compressions, 2 ventilations, log roll the patient, place the posterior pad. 30 compressions, 2 ventilations, place the anterior pad. And then we did a full minute of CPR and did sequential shocking for DSED. So it's quite easy to do. And this is something that was practiced and that our paramedics did as if it was quite simple. So you log roll the patient, posterior pad, place the anterior pad, you're ready to go. In AP, again, that should not take any less time than 10 seconds. Why AP for VF and AL for atrial fibrillation? You're defibrillating a different portion of the heart myocardium. So AL for atrial fibrillation, the rhythm disturbance is a different part of the heart than VF. So AL, you're up at the SA node and AV node. When you're in VF, you're down at the Purkinje fibers. So it's a different portion of the heart. The area where the heart most likely refibrillates is the posterior inferior part of the heart. You almost completely miss that with AL defibrillation. So I think there's actually good reason in physiology why AL for cardioversion and AP for defibrillation.
Fantastic. Okay, that clears it up in my head so beautifully. So when it comes to pad position, we want to use anteroposterior, the sandwich, for cardiac arrest. And the way to do that is you start compressions and then you time a quick log roll for the AP pads and then deliver your first shock. Excellent. Any comments, Rob, about the logistics of that in the emergency department? Like Sheldon described it beautifully for EMS, but what about in the emergency department? Let's say the patient comes in with AL pads. Do you put them in AP or do you try shocking a VFib just with the AL first? What's your approach?
Yeah, so I think from a trying to minimize interruption in CPR type standpoint, I totally agree. The anterior lateral pad placements are going to be easy and more feasible. Rolling a patient to put the AP pads on, I get how that's going to potentially add a little bit more, we'll say, time to getting them on. But if Sheldon's describing a benefit to it, then by all means, I'm much more going to follow that if there's a better chance that we can terminate the ventricular rhythm into something that can potentially give us a ROSC. Now, there's a couple of things that I do that are helpful, although if Sheldon's saying that, whether I get the pads perfect and anterior lateral, there's still maybe a benefit to doing anterior posterior. One of the things that I generally do is I look at where the pads are placed. I'll take a quick look at the heart, and I'll make sure that the heart is sandwiched between the two pads. And I take a look at the heart with ultrasound, of course. So I'll do a POCUS, find out where my heart is, and make sure my pads are appropriately sandwiching that heart. So I'm not doing what Sheldon's describing and basically defibrillating the spleen. So that's the other thing that I'll do, is make sure that my vector is going through the heart. And in the anterior lateral pad, which in my experience, the picture on the pads, the majority of the time now, are the anterior lateral picture. So they're being placed in that mainly because the picture's that way. And sometimes the feedback device, we have like this puck that's attached to the pads. It only allows you to do anterior lateral and doesn't allow you to do anterior posterior because the pad's kind of attached to the feedback device that goes right in the center of the chest. So that's another potential thing, is that depending on what pad you buy, you may be, forced to do an anterior lateral pad placement.
Rob, I'm going to have to challenge you there. So isn't POCUS going to delay your time to defibrillation even more? I mean, I can't imagine using POCUS, someone goes into VFib arrest in front of my eyes. The last thing I'm thinking about is POCUS. I'm thinking, how am I going to defibrillate this patient as soon as I possibly can?
In those cases, getting the pads on, and I'm defibrillating as fast as I can. But after the third shock or after the second shock, when I realize I'm still no further ahead and I still have VFib on the monitor, I start to question, why am I not terminating this rhythm? What can I do better to ensure that these standard shocks are going to be more successful? And the whole concept of dual sequential and vector change is that you're sending vectors through the heart to optimize the chance that one of those vectors is going to terminate that rhythm out of VFib into something that's going to provide you with ROSC. And on the second or third pulse check, I'm placing my probe over the heart, looking at the heart, doing my usual assessment of the heart. What kind of contractility do I have? Am I got any reversible causes that I can reverse? And are the pads placed appropriately that the vector would go through the heart? It's not the first thing I'm doing. I'm not taking my time perfecting the pad placement. I'm getting that first shock done in as timely a manner as possible. It's the subsequent shocks that I would want to make sure that I've optimized this. And I've really learned this through the stable AFib that we're deciding to cardiovert in the emergency department. Maybe I'm asked to sedate a patient, and I sedate the patient and my colleague goes to shock them and it didn't work. They're still in AFib. I'll take my probe and I'll look at the heart and I'll say, well, I would probably have put this pad a little bit higher up. Let's move it. And then on the next shock, while the patient's still sedated, we get a normal sinus rhythm. So I'm now just using that into my VFib treatment when I'm taking care of my shockable patients.
Fair enough. Thanks for that clarification. I want to talk about timing of shocks. So again, we all know that the sooner the shock for VFib, the better. But the question I have is about that second shock. Sheldon and I will remember in the old days, we used to stack shocks. When is the best time to give that second shock and why? To me, it seems like maybe we should be going back to stacked shocks. What do you think, Sheldon?
Again, the idea of a 2-minute CPR interval is really quite foolhardy. There's no evidence that 2 minutes of CPR makes any sense. The vast majority of patients who get defibrillated, when they refibrillate within the first 30 seconds. Yet we're doing another minute and a half of CPR when the patient's clearly in VF. So the issue is that there's no strong evidence there's no trial evidence, obviously, that shocking the patient as soon as they go back into VF is what is to be done. But physiologically, that makes the most sense to me. As well, now that we have decent, and I'm not going to say perfect, but we have decent see-through CPR algorithms. So these are filters that are built into the defibrillator that filter away ongoing CPR and let you see the underlying rhythm. Oftentimes we can pick up refibrillation very early. So I think the question becomes, should we be doing 2 minutes of CPR and shocking 2 minutes apart, or should we re-shock as soon as we see refibrillation? My gut feeling is shocking when you see refibrillation is likely going to be more effective if we ever do that research question. So stack shocks, I want to differentiate that out from how we differentiate shocks in DSED. So stack shocks were generally shock, see VF come back and shock in. So you're talking about 10 seconds. Those are essentially two independent shocks. In DSED, the shocks are 500 milliseconds apart. So they are actually still two independent shocks, but the myocardium is very, very different when it's 500 milliseconds apart than 10 seconds apart. So you're more likely with a DSED shock to see a different VF waveform than the first of the two shocks saw, where that's not likely the case in two stack shocks. So I don't know if I'm a big fan of bringing back stack shocks. I'm more a fan of defibrillation when we see refibrillation occur earlier than the 2-minute cycle.
I want to talk about shock energy. We've covered timing of shocks and pad position, and we'll get to dual sequence defib or DSED, which we've mentioned a little bit already, but we'll get deep into that in a minute. Sheldon, in terms of shock energy, why not just give like 400 joules instead of the standard 200 joules up front? You had mentioned it's about current, and then there's like impedance and all the stuff. Like, why not just give more energy?
Yeah, so I actually believe we should be giving more energy to a point, right? So I think there's a point in which you can actually damage myocardium if the amount of energy provided is too great. But the specific question is, again, it's not energy, it's current that makes a difference. And current is based on really directly related to transthoracic impedance. And that's the essential reason why AP defibrillation is more effective as a transthoracic impedance, and the AP plane is always less than it is in the AL plane. You have two ways to defibrillate people now. You have an escalating energy. So if you have a Zoll device, you go 120, 150, 200. If you have a Stryker device, you go 2, 3, 360. My belief right now, and I think it's played out in the guidelines, is we're moving to a high energy, high current strategy for all shocks. So we'll begin 200, 200, 200. If I have a Stryker, we'll start 360, 360, 360. We won't go with it. And I think the reason for that is you get greater current with these shocks, and therefore we have a greater chance of successfully terminating VF with that particular strategy. And I think that's what the guidelines are moving towards as well. And you'll see it in the AF guidelines. They clearly suggest going to a higher energy for the first cardioversion attempt. I say the same thing for VF.
The one thing that always comes up is the patient that is very hirsute or very hairy. And in these patients, the pads just sometimes don't stick to the patient. Do we go to the old school paddles if we have them, or should we shave the chest? Rob, what's your best strategy for patients with lots of hair on their chest?
I personally won't have this problem when I have a cardiac arrest. Those pads will have no problem sticking to this chest. But I have come across that person. You need to have some strategies because those pads just will not stick. Even in like a basic AED pack that we have in the community, you can have razors that are in there that will help provide you to clean up the chest a bit so you can get the pads to stick. We do have razors in the emergency department as well at all the sites that I work at for this purpose to get the chest clean of hair so we can have the pads stick on. But say you don't. You need some tricks in your bag of tricks. So this is what I would do. Really what you're going to do is you're going to do a $300 wax job. Those pads can cost up to $300, and you're going to sacrifice those pads to the benefit of the patient. You're going to place the pads on the patient over top of that hair. You're going to push on them as best you can, and then you're going to rip them off. I'm talking like Steve Carell screaming Kelly Clarkson in the 40-year-old version type rip off, where you're going to like get all that hair off there, and then you're going to put a fresh set of pads right in that place. If you have an AED in the community, they usually come with 2 sets of pads, one with the pediatric pads, one with the adult pads. You put the pediatric pads on your adult first, rip them off and wax that hair off, and then you put the adult pads over top. The other thing too that you can think about, we actually still have at one of my sites, the manual paddles, and you can just use those paddles. Make sure you're giving a good amount of force on those paddles. Make sure that you're standing clear and that you're not going to get, injured by the patient's flailing limbs in certain various areas of your body. And go ahead and shock them manually, apply an appropriate amount of pressure so that you're ensuring that you're sending a vector through that heart and get a ROSC.
I love that. What a great practical pearl to use the pads like they're a hair wax removal technique. Sheldon, any thoughts on hirsute patients?
Yeah, so that's the group that I would use manual pressure augmentation. So those are the ones where I would actually physically put my hands on the pads and apply pressure to the pad. That's been shown in multiple studies to decrease transthoracic impedance. And actually, there was a randomized trial in Australia that began that was showing some promising results using that technique. So manual pressure augmentation is what I would do in that particular subgroup.
That assumes the myth that touching the patient while they're being defibrillated does not hurt you.
Exactly.
Okay. This is the big topic that I know that both of you have a keen interest on talking about, and it's the patient that we presented at the top of the podcast, and that's refractory VF. We've covered the basics of shock timing, a pad position, shock energy, the hirsute patient. So let's move on to this refractory VF. So just to remind our listeners what refractory VF is, what the definition is, it's VF resistant to at least 3 defibs of 200 joules plus amiodarone 300 milligrams plus no ROSC after 10 minutes of CPR. And now just to be clear, the AHA guidelines, again, have no recommendations on managing these patients, which we do see not infrequently. Now, before we talk about refractory VF, in terms of definitions, I just want to ask Sheldon, what's the difference between refractory VF, recurrent VF, and true shock and failure?
So in dose VF, we used a pragmatic definition of refractory VF. So pragmatic definition is what you described. So a patient presents in VF, 2 minutes to CPR, still in VF, 2 minutes to CPR, still in VF. So a pragmatic definition is what the paramedic or the resuscitationist actually sees. What's the rhythm at the end of my 2 minutes? I don't care what happens in between those 2 minutes. All I care about is what's the rhythm after 2 minutes of CPR. So that's a pragmatic definition of refractory VF. An EPS definition of shock refractory VF is someone who has a shock and the patient never comes out of VF at all. So that's really shock refractory VF. Whereas recurrent VF is you have a shock, the patient goes into a non-VF rhythm for a period of time of up to 5 seconds, and then the patient goes back into VF. So that's known as shock recurrent VF. The classic teaching has always been that if a patient has shock recurrent VF, it's actually not a defibrillation problem. It's a resuscitation problem. It's a drug problem. It's an LAD that needs to be opened up, but it's not a defibrillation problem. And I think what we were able to show in some of our secondary analysis at dose VF that DSED was even effective in shock recurrent VF. So there's this thought process that if it's recurrent VF, that it actually came out of it, it's not a defibrillation problem. Our research group would say otherwise. We would basically say that if someone comes out of VF but goes back into it, you should do better defibrillation. It's not necessarily an LAD, a drug problem. And I think that's really important. For those who are truly shock refractory, our study, no one who did get standard defibrillation, standard AL defibrillation, very rarely will come out of true shock refractory VF.
Sheldon, before we get into the nitty-gritty of the literature on dual sequence defibrillation or DSED, can you explain for us the rationale behind dual sequence defibrillation? I've always wondered personally, is it because of the increase in energy being delivered, that adding 2 more pads simply increases the chances that the energy vector will go through the heart? Or is it a combination of both? Or is it the impedance, which I must admit I can't even remember from undergrad physics what impedance even is?
Yeah.
Or is it something else? Like, how does DSED actually work?
I think now we're fairly convinced that DSED provides a much more homogeneous distribution of current across the whole ventricle. Hey, listen, if we could put 5 or 6 vectors, everyone would come out of VF. Trouble is you can't put 5 or 6 pads on a patient, right? It just physiologically, there's no room to place them. So I think what we're showing now in some of our secondary analysis, there's no question you defibrillate a greater proportion of the ventricle than you do with a single vector in either AL or AB plane. So adding vectors makes a difference. The second issue that I think is likely a factor is that the initial rhythm that patient present in VF after they have that first of 2 D shocks is very different from what the second defibrillator sees, and it makes it much more susceptible to the second shock in a DSED pair. So I think it's more coverage of the ventricle the actual ECG rhythm. What I'm believing right now that it's not related to we're giving more current. Like I think everyone think DSED works because it's more juice. It's actually not the more juice that makes a difference. It's actually the coverage of the ventricle that I think makes a difference.
Getting back to logistics, and the same logistics with POCUS and with placing AP pads versus AL pads, there's a concern out there that DSED may delay high quality CPR. Sheldon, how does using DSED intersect with the primacy of uninterrupted chest compressions?
Listen, if you look at dose VF, you look at all three arms, vector change, standard, DSED, CPR quality metrics were exactly the same in all three arms. What that tells me is that if you train and you do things well, CPR quality is excellent. So to do DSED, like I said, 3 shocks, and the patient already had AL pads on. 30 compressions, 2 ventilations, log roll posterior pad, 30 compressions, 2 ventilations, anterior pad, 1 minute to CPR, 2 sequential shocks. The chest compression fraction in the DSED group was 80%. Vector change group was 80%. Standard group was 80%. So the interruptions in CPR were exactly the same throughout. This is a matter of training. If you train people to do it properly, then you will not have any significant interruptions in CPR quality. And I think we were the only DSED paper that had ever previously commented on CPR quality. I'm a believer that there's plenty of interventions out there that make a difference, but if you don't do good CPR prior to that, they may not show any benefit. I think that was one of the strengths of the dose VF trial was a high quality CPR regardless of the arm the patient was randomized to.
We've talked a lot about pad position. I've heard arguments that vector change, so going from AL to AP or going from AP to AL is a better idea than doing DSED. And then I've heard people say that DSED is better than vector change. What's your take on DSED versus vector change in refractory VF?
Listen, vector change is what the ERC ended up recommending for refractory VF based on 2 things, that there was the logistical concerns about DSED and there was not enough evidence for DSED, although all the evidence for vector change came from the dose VF trial. So we think that that's actually nonsense. And this idea that vector and DSED are the same is completely false. If you actually look at the trial, the point estimates all favor DSED. Sensitivity analysis all favor DSED. If you look at an intervention that improves survival, but it doesn't improve ROSC, which is what happened with vector change, there has to be confounding. It's impossible that you don't improve ROSC but improve survival. Neurologically intact survival was only improved by DSED, and rearrest was highest in the vector change arm of all the 3. Vector and DSED are not the same at all. If you have 2 defibrillators, no question DSED is what you would do. If you only have 1 defibrillator, then vector change is reasonable, but we really take a very hard line about people who say vector and DSED are the same. They are not the same intervention.
Sheldon, as you say, your great research suggests improved outcomes with DSED and refractory VF. And most of us will turn to DSED after the 3rd standard shock. But then the question becomes, well, if DSED is so great, why not just use it earlier? Like, why don't we just start with DSED or do it after the 1st shock? I understand that there's some Swedish data that suggests that there might be harm with early DSED, and then there's some other data that suggests it might be better to start DSED earlier. What's your take on the timing? What do you think the future is for using DSED in terms of after the 1st shock, 2nd shock, 3rd shock?
Yeah, so if I was going to do another trial again, it would be DSED versus vector change. That would be the trial that I would do because dose VF wasn't really powered for that, and that wasn't a focus of our actual study. So we weren't powered for that analysis. But if you look in Europe right now, 3 of the trials that are being done in Europe, Sweden, Norway, and Denmark are all DSED after the 1st failed shock. And the Swedes, you may have incorrectly mentioned that their data suggested that there was a harm to DSED. In fact, they presented at ERC their data from their feasibility trial of DSED after 1 failed shock. And what they were able to do, 3-to-1 randomization, DSED to standard defibrillation after one failed shock, 80% of patients got DSED within the first 2 shocks. Survival in the DSED group was 41%. Survival in the standard group was 9%. If you look at VF presenters, survival was 62% for those who presented in VF, 12% for those who presented in VF and got standard defibrillation. So there clearly is a signal from the Swedish data that is very consistent with our data that you spend less time in VF, you do DSED earlier, people are going to do better. They're now on to the definitive trial as they finish the feasibility. The Denmark trial is DSED versus vector versus standard. Norway, they're doing DSED as the initial shock because Norway is the only place in the world that does 3 minutes of CPR. So they figured if they delayed it to after one shock, they're doing 6 minutes without an intervention. They didn't want to do that. And in Germany, they're doing dose VF2, DSED versus after 3 failed shocks. So of those 4 European studies, only the German study is a confirmatory study. All those other 3 studies, those are all looking at early DSED, and the Swedish study suggests very, very strongly, although again, small numbers, but certainly there's a signal that earlier is better. And many of my institutions that do DSED, certainly in North America, do it after the second shock already, and people will wait for these data to see if they should do it after the initial shock.
Wow. That would be such a game changer.
From a defibrillator manufacturer, if I was looking at this, people say, why don't they make a defibrillator? 1 defibrillator, 4 pads, 1 button, 2 shocks, 10 milliseconds apart. Once you see a confirmatory study to dose VF, I think you're going to start seeing that type of technology around. That's the future I see of defibrillation. But again, you need a confirmatory study. And if I was going to say, hey, listen, is there an argument against the finding of dose VF? I would say whenever there's only one trial, you have to be a bit cautious, no question at all. But the one question, even the naysayers and I like the POCUS naysayers, obviously there's DSED naysayers. The question no one can answer is, what is the harm? You have a patient's had multiple shocks, is in VF. Tell me what the downside is of doing DSED. And no one can answer that question because there is no downside.
Right. And there's the myth of breaking the machines.
That is one of the biggest myths ever propagated. We did a survey looking at this particular question. 1 in 1,000 risk of damaging a defibrillator doing DSED. The only cases where they were damaged was when you were doing simultaneous DSED. And even if you do that, it's pretty rare. Not a single case to date has been reported of damage to defibrillator doing sequential DSED. And that's why now all the companies, before Stryker wasn't covering DSED on their warranty, they just released a new position that if you buy their warranty, they actually cover DSED. So all the defibrillator manufacturers know that was hocus pocus, especially by doing sequential DSED. So yes, this whole damage issue is now been put to rest.
Yeah, it's going to be really interesting to see all those European study results. And if they are, robustly positive, I can see the manufacturers racing to produce a defibrillator that has 4 pads and does DSED automatically. We can add that to the impedance devices, the mechanical CPR, and
Exactly.
We've got a whole long list of fun toys we can play with.
I always find it really amusing from the manufacturer point of view. I guarantee you they have this already. These people aren't dumb, right? They have this stuff already. I remember when I first published Dose VF, I got a call from 2 engineers at University of Chicago, first-year engineering students. They said, Dr. Cheskis, we have a prototype already. 1 defibrillator, 4 pad, all the capacitors. It's like a minor engineering thing. This is not rocket science, although the manufacturer would make you think so. It's very, very simple to do. So it would not be a difficult task, I don't believe.
Let's move on. We have our patient here. Let's say we've shocked 3 times, standard shocks. Then we've done DSED, and the patient's still in refractory VF. Rob, now we're like way outside the guideline recommendations here. What are your next moves? There's esmolol, there's stellate ganglion block. Walk us through how are you going to take care of this patient?
Well, now you're talking my language, Anton. This is the kind of case that gets me excited. And luckily, I've had some success expanding outside the guidelines. So, no question, every shock that I do from now on is going to be a dual sequential shock. So, every 2 minutes, I'm dual sequential defibrillating. And I'm holding that epi. The epi is going to potentially excite the heart more. And this heart's already fibrillating away and it's already extremely excited. So let's hold off on giving any more epinephrine. We're actually going to start thinking about reversing that epinephrine. Let's get some beta blockade on board. Some small trials have indicated that medications like esmolol, 0.5 milligrams per kilogram is a bolus dose. So up to 50 milligrams can be given as your dose to help reverse your epinephrine effect and kind of settle down the heart a bit. Hopefully make that next dual sequential work as well. All good things to consider. And if you want to give even further dose of esmolol, they recommend it as an infusion to give at like 50 micrograms per kilogram per minute if you want to give further doses of esmolol. Now, you brought up something, the stellate ganglion block. And once again, POCUS for the win. There is another thing you can put in your bag of tricks when you have your electrical storm patient or when you have your refractory VF patient, and that's where you can use local anesthetic around the stellate ganglion to terminate the ventricular fibrillation. That would be my next go-to if my dual sequentials and my esmolol and stopping the epi kept this person in refractory VF. I would move towards doing a stellate ganglion block to see if I can terminate the ventricular fibrillation.
Okay, I have to admit that when I first heard about stellate ganglion blocks, to me, it seemed like this insanely crazy procedure. While someone's getting CPR, you're going in there and trying to find this little nerve in the chest somewhere. And it seemed like totally nuts. But I understand that it's actually quite simple to do with POCUS. Rob, could you kind of run through for us just quickly the technique? And we'll have some videos or images or both in the show notes. If you can run us through your simplest, easiest technique and how you manage doing this during CPR.
Well, Anton, if you have good POCUS needle guidance skills and have done procedures like IJ central line, a stellate ganglion block should really be a walk in a park for you. It's very straightforward. We're going to start with the probe in the transverse plane on the patient's neck, and you're going to find your carotid artery. Now, when you have your carotid artery on the screen, you could do a little bit of a micro sweep to help clean up your image to make it as sharp as possible. And really what you're trying to do is you're trying to get your carotid artery on the screen, and you're going to try to get your longest chole muscle of the neck. And the stellate ganglion block is going to be sandwiched between the two, really at the 6 o'clock position of the carotid. If you forget about the muscle in general, if you just look at 6 o'clock to the carotid artery, the stellate ganglion nerve is going to be there. It looks like a star, hence why it has the name stellate to it. And then you're going to go ahead in plain view. You're going to put your needle in the plane right underneath the ultrasound. So just a reminder, if you're doing something in plane, you're going to visualize the entire needle on the screen, not just the needle tip, but that entire needle that's under the probe on the screen. And you're going to follow it down to that 6 o'clock position of the carotid artery. Of course, missing the carotid artery, you don't want to puncture the carotid artery. And you want to get it to the area where the stellate ganglion nerve is. And then you're going to aspirate back to make sure that you're not in the artery. And then you're going to slowly inject your lidocaine or your bupivacaine, or if you want to mix them together, your lidocaine-bupivacaine mix, and try to bathe that nerve with 5 to 10 cc's of your local anesthetic on the left carotid artery at the 6 o'clock position around the stellate ganglion. And that should hopefully, as studies will suggest, terminate your VFib. I've seen this happen in real time, in real life when I've done them. And I've heard of my colleagues also doing this with success as well. And you're going to hopefully terminate that back out of VFib into a nice ROSC rhythm. Now, you might ask, should we stop CPR for this? I'd leave that up to you and you're comfortable with this. You don't want to stop CPR for 2 minutes, 3 minutes while you're doing this. In fact, you don't want to do that even for 20 seconds. You're really going in, you're making sure that your needle's in the right spot, you're aspirating, You're slowly injecting, you're seeing the fluid accumulate around the stellate ganglion on the screen. And when you see that, then you're injecting further and you're done your procedure, kind of thing. If you need to stop CPR for more than 20 seconds, you should probably not do that. You shouldn't stop CPR for more than 10 seconds. This should be something that someone who has general POCUS skills and does central lines that they should be able to do during CPR on the left side of the patient's neck to help get that patient out of VFib.
Fantastic. Who knew that doing a stellate ganglion block was actually not that difficult?
If you know, you know.
Great. In our chain of survival, we've dug deep into high-quality CPR, ventilations, and defibrillation. At this point, I want to move the conversation towards epinephrine. There's a lot of controversy. We need to talk about the dose. We need to talk about the timing. The guidelines suggest 1 milligram of crash cart epinephrine every 3 to 5 minutes for all cardiac arrests. And as we've just discussed, it's going to be very different in VFib than it would be in asystole or a PEA arrest. I'm always a little bit unsure myself outside of VFib, so for the asystole and PEA arrests, when I should stop giving epinephrine. We know that we want to give epinephrine as soon as possible after the arrest starts, but by the time they come to us in the emergency department, they've already usually had 2 or 3 doses of epinephrine. And I'm always unsure when to stop it. I mean, my general rule of thumb is stop it after 3 doses, but the guidelines don't say that. Sheldon, besides knowing that we need to give epinephrine as soon as possible, A, when do we stop giving it every 3 to 5 minutes in the different kinds of patients? And then B, what dose do you think is the ideal dose of epinephrine?
So, fantastic question. Again, this is where you can't make an answer with a sledgehammer, like one answer fits all. I think it's really, really dependent upon the rhythm that you're looking at. Is it shockable? Is it not shockable? Early, as you mentioned, Anton, 100%. 1 milligram, try to give it as early as possible. What's the optimal dose? I think we don't know what the optimal dose is, to be perfectly honest with you. I think too much epinephrine, we know for a fact, is excellent at getting ROSC, but also is associated with neurologically intact, poor survival, as we saw in the Paramedic 2 trial. But again, remember, Paramedic 2 was placebo versus full dose epi. The question is there a sweet spot somewhere in the middle? And that's where the epi dose trial is looking at currently a maximum of 2 milligrams versus a maximum of standard, let us say 6 milligrams in cardiac arrest. So I think the answer, if we look at animal models, there's pretty good animal studies that suggest at 2 milligrams, you can actually get ROS without impacting cerebral perfusion. At 3 milligrams, you start seeing animals impact cerebral perfusion. So I think that 2 milligrams seems to be a reasonable answer in terms of where to stop in shockable rhythms. In non-shockable rhythms, I really don't think it makes a huge difference, to be honest. Asystoles, most of them are going to die anyway, regardless of how much epinephrine. And I think for the PEAs, this is where Rob comes in. You're giving epi, you're using your POCUS, you're assessing whether this is pseudo-PEA. So I think there, I have no great answer in terms of what the proper dose is for asystole or PEA, but I would minimize epinephrine in shockable rhythms.
So shockable rhythms, minimize epinephrine. We probably don't want to give any more than 2 milligrams. But for non-shockable rhythms, I have to agree, by the time they get to us, if they've been in asystole for a long time, I think we're going to be calling the code pretty soon anyhow. But for PEA, Rob, what's your take on the best dose of epinephrine? Let's say they've been in the field in PEA and have had 3 doses of epinephrine, 3 milligrams total. When do you stop? What do you do?
In non-shockable rhythms, in asystole, really, the outcomes are so poor to begin with. The studies basically say that repeated doses of epi, you might get a ROSC with it, but you're not going to get favorable neurological survival. And I think the more epi you're giving, the worse outcomes you're going to have. Now, PEA is an interesting one. I might give as many as 2 or 3. I might give 0. All depends on PEA. PEA is absolutely fascinating. No 2 PEAs are the same. No 2 PEAs are the same. It is this unique, fascinating group of patients that come in that get all labeled as PEA. And I think we can do a better job with how the algorithm reads currently, that PEA is not give epi as soon as you get someone in PEA, think of reversible causes, and do high quality CPR if that is your approach to PEA, you're going to have incredibly, incredibly poor outcomes. The same outcomes as asystole in my mind. So the reality of things is that all PEAs should be considered individually, and that you need to know lots of information about your patient who has PEA in order to find out what is causing this person's PEA and how am I going to manage that. Now, if they're in true PEA, that might be treating them similar to asystole, where you're doing high quality CPR, giving epi every 3 to 5 minutes and thinking of reversible causes. But at the end game, we do know that giving 5 or 6 epinephrines is not the right answer. So finding out what's going on in this PEA and having a better sense of what's causing this. Is there any sense that this person has outflow of any kind? I might switch them from giving boluses of epinephrine to an infusion of norepinephrine and then start reversing the causes and finding out, is this just a severe shock state masquerading as a PEA? If that's the case, my survival is going to go way up. If I, just treat that same patient as the algorithm reads, my survival is going to go way down. So it's very unique and requires a very good understanding of what true PEA is and what pseudo PEA is to understand exactly how you're going to manage and treat that patient.
All right. Yeah, Rob, I'll refer to the podcast we did on PEA and pseudo PEA. We talked about this extensively then. So yeah, if you are interested more in PEA arrest, please do go and check out that podcast. I want to move on to vascular access and drug delivery and talk about intramuscular epinephrine and IO epinephrine and IO for other drug delivery as well. So Sheldon, a couple of recent studies have explored IM, intramuscular epinephrine, as an alternative to IV administration in the early phases of cardiac arrest, particularly in the pre-hospital setting where IV access may be delayed. This raises the possibility of faster drug delivery, but with important questions about absorption during low flow states. Some of the studies suggest improved outcomes even with intramuscular over IV epinephrine. Based on the emerging data, do you see IM, intramuscular epinephrine, as a viable early strategy when IV access is not immediately available? Or are there physiologic and outcome concerns that should temper enthusiasm until more definitive trials are completed? What do you think?
Yeah, so I'm a big fan of IM Epi. I know Scotty Youngquist and his group in Salt Lake City in Utah did the original study, 5 milligrams IM Epi, which is actually the equivalent of 1 milligram IV. So 5 milligrams, so there's lots of studies looking at blood volume and blood concentrations. That 5-to-1 is actually the correct dose. And I think the beauty of IM Epi, if you look at it from a paramedic point of view, is it's easier to give by a larger number of paramedics, right? So if you have paramedics who are not trained in IV access, IM becomes a usable solution. In fact, first responding firefighters could theoretically give IM medication. So if you're looking at getting drug into the system as early as possible, IM is a reasonable approach. I know the folks are working on a randomized trial to look at it, and I think it'll actually clear up some questions. But I think there is some physiological reason to suggest it may work. I know Janice Thiessen in London, Ontario, is doing the PRIME trial, looking at IM epinephrine in the pediatric age group. So they're using 1 milligram of IM, and you can imagine in the peds group how difficult it is to get an IV IO, particularly in the peds group. This sounds like an excellent question to be answered. So that trial is ongoing right now. So lots of research interest in this, and I think it may actually be of benefit. So it'll take some time for the trials to come out, but I do see the physiological basis by which it may work, and also addressing that question of early as possible drug administration.
Yeah, so let's look out for PEDS IM epinephrine. It's definitely something to consider. The other route to consider when IV access is challenging is IO. One of the big changes in the AHA guidelines has been around the use of intraosseous access. And my understanding is that there's 3 RCTs that failed to show benefit of IO over IV access despite faster placement. But on the other hand, my understanding is that you can effectively use POCUS to place an IO, and that increases the chances of it working well. So maybe those studies failed to show the benefit because we're not using POCUS. I'm not sure. I guess it depends also on your POCUS skills.
All that being said, Rob, what do you think the role of IO in cardiac arrest is for you? And what do you think it is for our listeners?
Yeah, for the longest time when I was teaching the guidelines, IO and IV were considered equivalent. And then for the last couple of guidelines, now they're saying we should be rethinking that and that IV is really the gold standard right now, and then IO is kind of secondary. The reality is that the reason why IOs are not considered equivalent to IVs is because they're very hard to confirm that they're in the correct place. Because all the things that we would normally do to confirm they're in the right place clinically, like is the IO firmly embedded in that bone? When I remove the stylet, was there blood at the tip of the stylet? When I aspirate the IO, does marrow come out? When I flush the IO, is there no extravasation? And if those were all true, then you were considered in clinically, but the reality is, even when all those were satisfied, you still weren't in the correct spot. And all of your drug delivery and use of that IO were for naught. So they basically said, we should focus more on IVs. They're more reliable in confirming that they're in. They're more frequently used. And at the end of the day, studies are now showing that IVs are the go-to ones so far, and that IOs can still be considered, and they should still be considered as a next line if IVs are not used. But the reality is that I don't rush anymore to use an IO when one nurse says, I'm having trouble getting IV access. 10, 15 years ago, it would have been like, just get me the IO drill. I'll drill one in, and boom, we got IV access. In fact, boom, now we have two. Nowadays, it's like, you know what? Like, let's get our most experienced person to get this IV in. We'll sacrifice a little bit more time to get that IV in. If you guys can't get it, then we're in for getting some IOs in or alternative methods of getting IV access. But then, there's also this other bedside tool that's readily available that can see if you're in or not, and that would be point of care ultrasound. And by placing the linear probe, the high frequency probe, right next to the IO, angling it so that you can see the flow through the IO into the marrow. When you inject and you have your color mode on, you can actually see where you're injecting. If you're doing a tibial IO, for example, you have your tibia on the screen. If you go and you inject and you see that the color on the screen of your POCUS machine is glowing outside the marrow, then you know you're not in. You've confirmed you're not in the right place. And vice versa. When you see it going directly into the marrow, then you know that IO is in, and then that the medication you're given is likely going in to be the place where you want it to go.
All right, let's say you have a patient who arrests in your ED or comes in without IV access. What's your go-to then? Would it be intramuscular epinephrine? Would it be IO epinephrine? Or would it be, let's say they're intubated, would it be down the tube?
First thing I would do is I'd have my most experienced nurses, especially at the places where I work, where they're quite good in the resus room. They manage sick people quite a bit. I would attack the IV first. And if they tell me we're not going to get IV access, I personally would then do IO.
And Sheldon?
Yeah, 100%. So I have a fair bit to say on this, so I don't mean to add, but although everything I say, I would agree with Rob. The Danish RCT, 30% of the humeral IOs were misplaced. They were not in the actual bone marrow. So definitely the risk of misplacement is significant. The other thing is that the reason IO has thought to be successful is thought to be quicker, right? But when you look at the randomized trial data, in fact, it was not quicker. IO and IV were about the same amount of time when you look at the first pass success time. So these are some of the dogma that get challenged when you actually put something under the scrutiny of a randomized trial. In fact, it would be very interesting in AL versus AP defibrillation. Is it actually faster when you actually get trained to do AP defibrillation? We may be finding something faster. What you think is faster may not actually play out. One of the biggest knocks, I would say, on IO is the drug absorption through the intraosseous routes. It is not equivalent to the intravenous route. We can tell you that for sure. In the Epidose trial, IOs are actually contraindicated because Paul Dorian is a very strong believer that the drug will not get absorbed and therefore is not as effective as IV. In fact, if you look at the Rock Alps trial, a trial that looked at amiodarone versus lidocaine versus placebo, 20% of those patients got IO antiarrhythmic. If intraosseous was removed from that, amiodarone was statistically significant to improve. So the inclusion of IO actually was a detriment to that particular trial. So no question whatsoever, I like exactly what Rob said. I would try really hard for an IV. Only after failure of IV would I go to IO, knowing though that drug absorption is not the same.
Is it fair to say that if you're agile with POCUS putting in an IO, then that is certainly better than intramuscular epinephrine?
I think we don't know that. I don't think, like, even with POCUS IO, I can just do an IM right away and it's done, right? So the speed will be much quicker with the IM route in my mind, but I don't think there's a study compares IM versus IO. So it's a good question. I would probably go with a quick IM, to be honest with you, in that situation.
So you've got choices there. Part of it, I would say, probably depends on your POCUS skills, because with a 30% miss rate on the IO, you might be better off doing IM. I would say that if part one of this two-part podcast on cardiac arrest had a theme, it's that CPR and defibrillation are still the most important things we can do, but how we do them really matters more than ever. And just following the guidelines and not understanding all these nuances is not going to improve our patients' outcomes. The 2025 AHA guidelines reinforce these fundamentals: high-quality CPR, early defibrillation, minimize pauses, control ventilation, optimize systems of care. None of that's new, but what is new is how much nuance there is once you move beyond the algorithm. We talked about compression fraction, recoil, end-tidal CO2 interpretation, art lines, feedback devices, head-up CPR, mechanical CPR, ventilation discipline, shock timing, pad position, shock energy, refractory VF, dual sequence defibrillation, vector change, stellate ganglion block, POCUS integration, and even TEE. And if that sounds like a lot, it is, because running a cardiac arrest in 2026 is not about just memorizing that flowchart. It's about understanding the physiology. It's about knowing when VF is truly refractory versus recurrent. It's about recognizing when ultrasound sharpens decision-making and when it distracts. It's about not letting hyperventilation sabotage perfusion. It's about realizing that after 3 shocks and 3 doses of epi, the guidelines go quiet, but the patient doesn't. And we're still not done. In part 2, to be released soon after part 1, we're going to tackle some challenging topics and questions like vasopressors and adjunct medications, which ones actually show evidence that they work. There's norepinephrine, there's amiodarone, there's lidocaine, there's bicarb, there's magnesium, there's calcium. We're going to talk about the role of ketamine in cardiac arrest. Is it humane sedation or neuroprotection or both or neither? We're going to talk about airway best practices, supraglottic devices versus ET tubes, and how not to destroy perfusion with ventilation again. We're going to talk about termination of resuscitation and when it's reasonable and how we make that decision thoughtfully. We're even going to talk about lytics and cath lab activation. Why are the criteria so strict, and shouldn't we widen them a bit? Should we really be ordering whole body CT on everyone post-arrest? And finally, we'll ask Rob and Sheldon to walk us through how they ideally run their codes from start to finish in a perfect world situation. Because beyond the guidelines lies the real art of resuscitation. So thanks so much, Sheldon and Rob, for helping us separate the signal from the noise. Join us in part 2 of Updating Cardiac Arrest Management Beyond the Guidelines. And until next time, take it easy.